Angiosarcoma, exploring the diagnostic challenges of hemopericardium. Authors include myself, Dr. Sasikant Ravi, Dr. Tushar Menon, Dr. Neha Khan, Sahil Kapoor, MS4, and our mentor, Dr. Michael Castro. The clinical history of this patient includes a 34-year-old woman who was hospitalized for persistent retrosternal chest pain with associated shortness of breath and mild tachycardia. CTA chest with contrast obtained in the ED showed a large pericardial effusion measuring 9.5 centimeters in the greatest dimension. She had a similar previous history of pericardial effusion found incidentally on CT abdomen 3 months prior, showing a large hemopericardium that was also confirmed by echocardiogram. She had an emergent pericardiocentesis, removing approximately 1 liter of hemorrhagic fluid at that time, and Coxsackie IgM and IgG were both negative, but antibodies were positive. Despite the negative serology, she was diagnosed with Coxsackie given the 1:32 antibody Coxsackie titers. Cytology of this pericardial fluid was also negative for malignancy. In addition to the emergent pericardiocentesis, she had a left-sided thoracentesis for pleural effusion as a result of heart failure for pericardial tamponade physiology secondary to the hemopericardium. A total of 150 cc's of transudative fluid was removed, and the cytology of this fluid was also negative for malignancy at that time. During her current presentation, due to the reoccurrence of the pericardial effusion, a very extensive laboratory studies were ordered, including viral, immunological, Coxsackie, and TB panel, as well as COVID PCR were all ordered and came back negative. Cardiothoracic surgery and cardiology at this time were consulted, and TE was done on day 2, which showed localized pericardial effusion along the right atrium and right ventricle with suspicion for thrombus. By day 3, the patient underwent complex surgery, status post subxiphoid pericardial window, right mini thoracotomy, transthoracic pericardial window, and median sternotomy, with mediastinal exploration on cardiopulmonary bypass to remove the organized thrombus. By day 8, surgical pathology reports show atypical vascular proliferation in the pericardium and interpericardial mass with CD45 positive cellular proliferation. After a cardiac MRI and second opinion from Cleveland Clinic, the patient was diagnosed with angiosarcoma involving the right atrium and extending into the level of the pulmonary outflow tract. Now, with the clinical history in mind, I want us to take a look at the bottom left-hand corner where you see the CT chest with contrast. What this figure is trying to illustrate is a large locule of pericardial fluid measuring 9.5 centimeters in greatest dimension. As you can see, there's a mass effect upon the right atrium and ventricle. Unfortunately, because of the time limit, we can't go extensively into the microscopic findings and the immunohistological breakdown of this, but from the clinical history, we have CD45 positive. Beyond the CD45 positivity, we use CD31, CD34, ETS, and Ki67 for the diagnosis of angiosarcoma. Now in the top right-hand side, you see the cardiac MRI. What this figure was trying to signify is a layer of contrast enhancement along the right anterior lateral margin of the heart adjacent to the right atrium, extending cephalad to the level of the pulmonary outflow tract. This was later diagnosed as primary cardiac angiosarcoma. To conclude this presentation, a cardiac angiosarcoma is a malignant tumor of the pericardium that typically manifests as an unexplained recurrent pericardial effusion. Depending on where the tumor is obstructing, it can present as a left-sided heart failure or right-sided heart failure with potential for pericardial effusion. Due to the non-specific presentation ranging from chest pain to heart failure, dyspnea is usually the most common clinical presentation that you can rely on. TEE and cardiac MRIs are still the primary ways of evaluating these cardiac tumors due to the high sensitivity of 97% when it comes to detecting cardiac masses. In order to categorize this cardiac mass, you still need the immunological stains in order to properly diagnose them as cardiac angiosarcomas. Despite the extensive diagnostic challenge of cardiac angiosarcoma, surgery remains the best option for palliative care and potential cure, with postoperative survival ranging from 2 to 55 months with a median survival of 14 months. Even with medical management, we are only getting about 9 to 12 months. However, the combination of resection, chemotherapy, and radiation therapy have shown survival up to 3 years. The purpose of this case study was to illustrate the necessity of early diagnosis and optimization of treatment to extend the poor survival rates associated with primary cardiac angiosarcoma. Thank you for listening to our presentation. Have a good day.